frontline providers in the room this evening, and we would greatly appreciate you passing on this information. If you have any questions at all, please speak with Bernice or Lulu. And there's information at the back on that little white table across from the coffee station, and phone numbers. The focus of the Shauna Project is on understanding women's experiences and barriers they face in positive sexual health and HIV treatment and care in Metro Vancouver. Shauna is a collaborative research project led by the Gender and Sexual Health Initiative of the BC Centre for Excellence in HIV/AIDS and the University of British Columbia in partnership with women's and HIV service and support agencies.
Wow.
In addition, part of our newest initiatives is the HIV Care Registry. For those of you that are not familiar with it, there are cards at the back of the table. What it is it's a registry that's designed to connect people living with HIV throughout the province with care providers who are experienced in providing HIV care and or welcome PL-HIV clients. So what it means, if you look at the card on the back, it tells you a list of services ranging from psychiatrists, mental health case management, alternative health, nurse practitioners, pharmacy, dentists, psychologists, other organizations. All you do is you go online and you can push in, it's very user-friendly, you push in the area that you live in and it will tell you the services that are available in that area. But more importantly, we're encouraging people that work in the HIV front line as service providers to register themselves online to allow for people, particularly people living in rural BC, to access some of the services that we so gratefully receive in the Lower Mainland. So again, this is information to pass on for those that are in frontline, and for those of you that live with HIV, definitely something for you to look at if you're looking for all sorts of changing care. I highly recommend that you check it out. The other thing I'd like to mention is the GPS program. For those that are familiar, there's cards on the back that they are again recruiting new participants. So those of you that would like information, you can certainly come and speak to me, and I believe there's navigators in the room this evening that could help with that as well. So that's not the last thing. So a big thank you off the top to our pharmaceutical sponsors, AbbVie, Bristol Myers Squibb, Gilead, Janssen, Merck, and ViiV, who make our community forums possible. Thank you. Just a couple of housekeeping notes. For those that don't know, the bathrooms are to the left and down the hall. We would appreciate if you take your time to turn off your cell phone. And also, we're very pleased to announce that recently we have added a webinar to our community forum and are delighted that we have, I believe, 10 guests joining us from across the country, perhaps across the country. Yeah, so we do have people online that are listening in, and we will be, hopefully, they will be engaging in the Q&A with us at the end of the presentation. A reminder also that this event is recorded for archival and promotional purposes to be added to our website. No audience members will be filmed, but just a heads up that it is being filmed. And lastly, we ask that everybody please hold your questions until the end of the presentation. We will have a lively Q&A. I will set the microphone, the alternative microphone in the center of the room, and we'll just have people line up to ask the questions. So, at this time, I will leave and introduce my speaker. That I'm delighted to introduce Dr. Julie Van Schalwick, who is an OBGYN with additional training in reproductive infectious diseases. She completed medical school at Dalhousie and her fellowship and additional infectious disease training at UBC. She provides OBGYN care to HIV-infected women at the Oak Tree Clinic in addition to her general practice. Julie's current research interests include HIV, HPV, and sepsis in obstetrics. Please join me in welcoming Dr. Julie. Thank you.
Good evening, and thank you for the invitation to speak with you this evening.
I have to admit, as an OBGYN giving a community talk, I usually don't see so many gentleman faces in the audience. That's very nice, thank you. So today what I hope to do is explain a little bit about HIV epidemiology in the global perspective, and then bring it home, providing you with some local data. With respect to HIV and pregnancy, we'll talk about diagnosis in pregnancy and how important pre-pregnancy counseling is if someone is known to be HIV positive before they plan on having a family. We'll talk about some of the important issues of antenatal care or care in pregnancy, how we prepare for delivery, and intrapartum care, care within the delivery, as well as how we provide care for mom and baby postpartum in order to maximize all health outcomes. So a little bit of background. Very simply put, HIV is an RNA virus, and it has an affinity for a certain kind of blood cell, a helper cell, specifically the CD4 positive T helper cells. The virus infects these cells and over time destroys them. With initial infection, most often you have a flu-like illness or you can actually be asymptomatic. And the natural history of HIV tends to be that over the course of about 8 to 10 years, there is a relatively asymptomatic phase where the CD4 remains above a level of about 500. And following this, it starts to decline. We know that as the CD4 count declines, there's a decreased cell-mediated immunity, one of those important things we need for fighting infection. And it leaves us open to opportunistic infections. Infections with organisms that we usually wouldn't get sick from, and also the development of cancers that we may normally not become victim to. With with HIV, we use CD4 to monitor our level of immunity as well as viral load. It helps us certainly to monitor how well therapy is working. So in 2012, the global summary of the AIDS epidemic revealed that over 35 million people were infected with HIV and actually living with HIV. And those people newly infected in that same year was over 2 million. Shockingly, of course, is that 250,000 of these were children. And those who died of AIDS in 2012 was 1.6 million, which included 210,000 children. This is a map that displays the proportional incidence of HIV globally, and we see that both India and Africa are well overrepresented. However, HIV affects every single country on the globe. And we have to feel fortunate that we live in Canada and we have resources available to us. The estimated number of children under the age of 15 who are newly infected with HIV in 2012 was 230,000 in sub-Saharan Africa. Fortunately, in North America, we see less than 200 infected children per year. And in Canada, that is much lower. In 2012, it was estimated that there were over 6,000 new HIV infections per day. The vast majority of these occur in low and middle income countries. About 700 of these are children under the age of 15. And about 5,500 are in adults aged 15 years or older, of whom half are women, and almost 39% are young, between the ages of 15 and 24. This is a growing population in terms of at-risk for HIV acquisition. In Canada, we know there are approximately 15,000 women to be living with HIV in Canada, and this is a 2012 figure, so that number is known to be higher. 18% of all HIV positive persons in Canada in 2012 were women, but this proportion is increasing as 23% of new infections in that year were in women. Most women who acquire HIV are of reproductive age. Many are marginalized women. These include Aboriginal and immigrant women. And we have also seen a substantial increase in the new diagnoses in the prairies, particularly amongst young reproductive aged women. This graph shows the number of mother-infant pairs that we are aware of in Canada. The total number of mother-infant pairs is almost 3,000, or it was as of 2011. You can see that the numbers of mother-infant pairs per year is increasing. What's going on here? Is it too loud?
No, it's too soft.
It's too soft.
You're not hearing it before.
Oh dear. Okay. Can you hear me now? Okay. This slide represents the number of mother-infant pairs from 1990 to 2011, and during this time frame there were almost 3,000 mother-infant pairs in Canada where mothers were infected with HIV. And as you can see, these numbers increase each year. In terms of maternal race and HIV in Canada, over time, Black women make up the proportion, the largest proportion of those women HIV infected and pregnant, and over time both Aboriginal and white women as well have also slightly increased in terms of their proportion. And how are these women acquiring HIV? For the most part it's through heterosexual, for the most part it's through heterosexual contact, next through illicit drug use, and much less through perinatal routes or other unknown routes. We know there are a number of risk factors for transmitting HIV from mother to child, and these include the increased illness severity in the mom. A high viral load and a very low CD4 certainly increase that risk. If the mom is not on antiviral therapy, there is a certain risk. Other factors that can contribute to an inability to be adherent to your medications or have other infections include maternal drug use. There are also a variety of obstetrical factors, preterm birth, abruption, antepartum hemorrhage. Those kinds of obstetrical factors can increase the chance of a leaky placenta, allowing for maternal and fetal blood to mix early in a pregnancy, and breastfeeding. So what this graph is attempting to show is really when during a pregnancy is HIV most likely to be transmitted. And there certainly is a small percentage of babies that will be infected inside the mom's uterus. However, the vast majority of transmissions are thought to occur within labor and delivery. In addition, postpartum with breastfeeding, there is also an increased risk. What I'm presenting here is data from about 20 years ago. And if you were a care provider during this time, you knew that any HIV medication that showed any kind of positive effect was one step towards really dealing and managing HIV. This AIDS clinical trial group study 076 looked at using intravenous AZT or oral AZT given to moms at the very latter part of their pregnancy and in labor, and in addition to babies for 6 weeks postpartum. An interim analysis that my colleague Dr. Money was actually a part of, and she describes the study being halfway done when the midterm analysis was undertaken. And she said when they got to work one morning, the fax machines were going crazy. The first look at what the transmission rate was between those treated and those untreated was astounding. It was 25% in the placebo group versus 8% in the treated group. This was the first step towards preventing mother-to-child transmission. And ultimately, the risk reduction in the final analysis was that in the absence of any HIV medication, your risk of transmitting to baby at the time of delivery is about 22 to 25%. But with one medication given intrapartum and then to baby, you could reduce that risk to 8%. Since that time, there obviously have been huge milestones met. There's a recognition that people with HIV have a prolonged life if they're started on medications early and are adherent. We have now entered the era of combined antiretroviral therapy. But we do know that there is a recognition of risk with this therapy in terms of undertreating, in terms of issues with adherence, and in terms of allowing for resistance to develop. Now, in this era, the question has always been, what does this mean for pregnancy? And regardless of what medication you're considering to use in a pregnancy, or what medication you'd like to study in a pregnancy, there is essentially no ethics board that's going to allow you to test a new drug in pregnancy. Particularly given the fact that with some of these medications, we've already shown a significant reduction, such as AZT, a significant reduction in terms of transmission rates. That being said, many drugs are not actually tested in pregnancy. They're simply tried, and we rely our safety data on anecdotal evidence or use that's already occurred. So just to give you a wrap up here, when we think about perinatal transmission, we know that in the absence of any therapy, transmission from mother to child is 25% with a vaginal birth. If you add breastfeeding to that, you add on an additional 5 to 20% risk of transmission. So up to 50% of babies born vaginally and breastfed by their infected moms in the absence of therapy will be infected. If you perform a C-section on that woman before labor, the risk of transmission is decreased. Depending on the study you look at, it's anywhere from 6 to 17%. So there is some protective benefit with C-section in the absence of any therapy to mom. And as I showed you previously, the first IV-AZT study found there was a significant reduction to 8%. When you added intrapartum nevirapine, so an oral medication to mom in labor, the risk was reduced to 2 to 3%. In 2002, when we started using combined antiretroviral therapy with C-section, if it was obstetrically indicated or not, the transmission rate is less than 1%. And something I'm always so happy to share is that since 2002, in women who have engaged in care, who have taken their medications, there are over 500 of these mother-infant pairs that we have cared for at the Oak Tree Clinic, and there hasn't been one transmission. And this always brings me back to this slide, which I also love to show those who may not be in the medical field or those who may not be aware of HIV. It is a chronic illness. It is no longer a death sentence. And that's true for moms and for pregnant moms as well. We know that if you're diagnosed really early in the setting of your infection and you start antiretroviral therapy and you're adherent, you will live as long as anyone else will. So getting to the medications. So we don't use just IV-AZT anymore. We use a combination of drugs. And as I mentioned previously, getting really good safety data, particularly in the setting of pregnancy, is tough. And it really is based on what has been used and what's worked okay. We know that antiretrovirals reduce perinatal transmission by a number of different mechanisms. One, it obviously reduces the mom's viral load. And we also provide baby with IV-AZT in labor to preload the baby through the placenta. And we also give baby infant prophylaxis, so oral AZT for a number of weeks, 4 to 6 weeks postpartum. Now this is a very sort of complex slide that brings me back to my days of cell biology and sort of gives me shivers, but I present it simply just to show you that there are a number of different points along the viral life cycle inside a T cell where certain drugs can work to help prevent the virus from replicating. Can you guys hear me, or is that an awful?
Special effects.
Can you hear me now?
Yeah.
Okay. And many of the classes of drugs that we do consider using in pregnancy are described here. We have reverse transcriptase inhibitors, there's protease inhibitors, but also, fortunately, for all of those affected by HIV, new medications continue to evolve. Unfortunately, as the virus continues to evolve too, and there are more resistance mutations, some women are going to present for care on medications where we actually have no safety data at all. So the care of women pregnant and HIV infected is an ongoing constant challenge in terms of trying to figure out what medications will work best for them and best for their pregnancy. This is a sort of a current list, but I know it changes frequently, and there may be some medications that I'm missing here. But the various classes of medications used to treat HIV include NRTIs, NNRTIs, PIs, entry inhibitors, and integrase inhibitors. Now I've highlighted with small little stars those medications that we really do try and avoid in pregnancy. Certainly the entry inhibitors and the integrase inhibitors, we don't have a lot of safety data on those. We know that efavirenz, which is one of the drugs in Atripla, a very popular medication because of its ease of use with once daily dosing, it's associated with congenital anomalies in the baby. So we do our very best to try and avoid that, certainly during the first sort of 13 weeks of pregnancy when babies are developing, as well as nevirapine. Not a drug commonly used, but historically it is associated with significant liver toxicity in the setting of pregnancy. So it sounds really easy when you present a slide and say that if you take these medications, your viral load will be suppressed and you will deliver a baby and there will be no infection. It's not always that easy. Pregnancy is not always that easy, regardless of HIV infection. We know certainly in the first 13 to 16 weeks you can have significant nausea, vomiting, diarrhea, headache. And these medications on top of that can make that worse. There can be bone marrow suppression with certain medications leading to anemia. You already get anemic in pregnancy and you feel tired and you feel crummy. Sometimes the medications make that worse. There can be liver toxicity, kidney toxicity. You can get inflammation in your pancreas with some of these medications. There can be peripheral neuropathy or some nerve changes over time, certainly over long use of medications. And something that we continue to study is a notion of mitochondrial toxicity, where drugs used over a long period of time and perhaps in the setting of pregnancy might actually change some of the structures of the mitochondria, kind of the powerhouses of our cells, particularly in children who are exposed to these drugs in utero, might have an effect on their health and longevity downstream. So we're still looking at that, we're still trying to understand that. Just to give you a little snapshot of those 500 women that we have followed at the Oak Tree Clinic, over 500 women. We know, all told, HIV-affected pregnancies are higher risk. They're higher risk for a variety of reasons, but two reasons is the lower birth weight that we tend to see in those HIV-affected women, and they have a higher rate of preterm birth. So we certainly treat these pregnancies very carefully. We monitor closely, and counsel our women that, frequent follow-up with their care providers is important so that we can do everything we can to try and minimize these potential outcomes. So the preterm birth rate, any baby born before 37 weeks is considered preterm. For all comers, it's about 5% is the rate in BC, but for those affected by HIV, it's 15%, so 3 times the expected value. And for those born less than 2,500 grams, again, about 4 to 5% of the provincial cohort of babies born is less than 2,500 grams, and it's 10% in those affected by HIV. We're still trying to figure out how the virus itself and how the medications affect the placenta and affect the development of the baby. Some of the other perinatal issues or issues that occur in pregnancy that can affect women is a double rate of gestational diabetes. That's a higher sugar level in your blood that's only present during the pregnancy, but if left uncontrolled can lead to a really big baby and a very difficult delivery. So we try our best, obviously, to screen everyone and ensure that they're managed appropriately with diet, exercise, and sometimes insulin. I've already mentioned this issue of higher rates of preterm birth and low birth weight. We also know that, and we have seen, certainly as these newer agents roll out for the treatment of HIV, A lot of the new agents we have absolutely no safety data on. So women coming to us on a tripla who've been exposed to efavirenz for the first 6 to 10 weeks of their pregnancy, we're unable to reassure them that things will be okay. The risks associated with comorbidities that we not infrequently see in our pregnant population at the Oak Tree Clinic, issues of malnutrition, substance use, domestic violence, the list goes on. So the general approach to HIV care for women from the OBGYN perspective is to remind us all constantly, HIV or not, 50% of pregnancies are unplanned. And as care providers, as friends, as brothers, as sisters, as lovers, we have an obligation to talk about it, and if it's not planned, let's prevent it. We should ensure as well that combination condom use and hormonal contraception or an IUD be discussed in conjunction with prescribing antiretroviral therapy. If a woman is planning on getting pregnant, don't put her on a tripla. Put her on a combination that we know has a lot of good safety data in the setting of pregnancy. We know for any woman coming for contraceptive counseling, it's important to ask and screen for sexually transmitted infections. We know that amongst marginalized populations, certainly sexual violence is more commonly experienced, and we need to ask about this. We also know that HIV-affected women have higher rates of cervical cancer or precancerous change on their cervix. And when their HIV is not well controlled, they should be screened more frequently. The general population now, it's annually until you have 3 normal results on a pap smear, on a cervical pap smear. However, if you're, and then after that it's every 2 years. For the HIV-affected women, it should always remain at least every year, and if not on therapy, every 6 months. And also, just in your general care, screening for all other cancers. Let's not be forgotten. So at the Oak Tree Clinic, in our first consultation, we see women who know about their HIV status and come wanting to know about pregnancy. We also have women who, as part of their routine blood draw at the first visit with their family doctor or their midwife or their obstetrician, has HIV screening performed, and it's positive and it's a big surprise. So women come to the clinic, and you can imagine the very first visit is it's pretty heavy. We try our best to provide basic information about HIV and what it is and what it means. We talk about their infectivity and how to protect those around them. We do blood work and do a physical examination to establish sort of the stage of their infection. And then we counsel them about the need for antiretroviral therapy, the effect of HIV on pregnancy, the effect of HIV or of pregnancy on HIV, how they can prevent their baby from getting this, and they can and they will. And we also talk to them about, whether or not this was a planned pregnancy and what their intentions are. And all of these, of course, are in whatever context that particular encounter defines, be it social, financial, geographic. So once we've determined their HIV status, we also look at risks related to other behaviors, for example, illicit drug use. Now this is a bit of an older slide. Historically, when we met a woman for the first time, or any adult diagnosed for the first time, if their CD4 was less than 200, they were put on medication right away. If they were pregnant and their CD4 was between 200 and 350, we wanted to get them on quickly. But in the setting of your first visit, when a woman is nauseous, vomiting, can't keep her medications down, or she's socially really scattered, the first visit or even the first trimester may not be the best time to start them, and helping them stabilize and get ready for adherence is usually more successful. Historically too, if a CD4 was greater than 350, we always just sort of waited until the second trimester after their detailed ultrasound, knowing that all of baby's anatomy had developed properly. But of course, we're now in the era of seek and treat, and our goal nowadays, particularly with certain ART regimens that we know are safe in every stage of pregnancy, we feel more comfortable starting with that. So again, in the first trimester, so in the first 13 weeks of pregnancy, we need to determine whether or not they need therapy right away. Have they come on a medication that we have no experience with in pregnancy? Do we need to switch them, and what will the side effect profile be of those medications? As I mentioned, we need to manage their nausea and vomiting, which may be related to not only their pregnancy, but perhaps even their new med start. We make sure there's a focus on vitamin intake and dietary needs. We have an excellent dietitian at our clinic. We also offer non-invasive prenatal genetic screening. So any woman pregnant in Canada is offered prenatal genetic screening. So what that means is a blood test that used to actually only be available through amniocentesis, the needle that goes inside the uterus, to determine a woman's particular risk of having a baby with Down syndrome or a defect in the development of the baby's spina bifida. We now know that these non-invasive tests are almost as accurate as an amniocentesis, and women affected by HIV are offered this test free of charge, which is wonderful because at around the time that you want to be able to offer these tests, many women are not on medication yet, or their viral load is not yet suppressed, which would make an amniocentesis risky. As mentioned before, we do our very best in these first 13 weeks to really assess and assist with stabilizing their social situation. By the second trimester, so that's sort of 13 weeks to 26 weeks, we really want to make sure all women are on medication for the most part. We start monitoring adherence and monitoring this through CD4 count and viral load done every month. As I mentioned, we get a detailed ultrasound to look at baby's anatomy and gender. We do diabetes screening during this time, and we then try and figure out where this woman wants to deliver. Where is the best and safest place, most comfortable place for her to deliver, and we start to set up telehealth or coordinated HIV care with their community provider. In the third trimester, obviously we switch up her medications if her viral load is not decreasing at the rate that we would expect. Usually it takes about 8 weeks of therapy in the setting of pregnancy to have an undetectable viral load. If not, we have to ask questions about adherence or perhaps resistance and make necessary changes. And then comes the time to plan for delivery. We also, as I mentioned, talk about location for delivery, what supports they have, and then prepare for infant care. I mentioned here too, we know that the risk of transmission with breastfeeding is increased by up to 20 to 25%. So in Canada, we do not support breastfeeding. Fortunately, we are a health care rich country, and we supply a formula for 12 months for every baby born to an HIV-infected woman. Planning for the delivery, again, as I mentioned, we do consider these deliveries high risk because of their variety, their myriad of medical issues, but also the risk of preterm birth and low birth weight. We consider cesarean section only if the viral load is greater than 1,000 copies per ml. And I can probably think in my 10-year career of only about 2 or 3 women who ever had a viral load that high that we needed to do a cesarean section. The vast majority of women are adherent and their viral loads are suppressed, and they proceed with a trial of vaginal birth. I'm not saying that many didn't go on to have cesarean sections, because we know they do. It's 20 to 30%, unfortunately, but not for reasons of viral load. We also make sure that we stress with the patient, with their families, with the care providers, that confidentiality is paramount. We've had some patients who have wanted no one in her birth room, no one in the postpartum ward to be aware of her HIV status. Now, of course, her immediate care providers had to be, because they were the ones who had to hang the medications. But we cover the bag with pressure cover. And we have very successfully managed these women with the utmost confidentiality, such that their status is never revealed. And I already mentioned mode of delivery. We only do cesarean section when, for HIV reasons, for when viral load is greater than 1,000. The other thing is unfortunately, there have been cases of women who've not been adherent. Their viral loads are above 1,000, and they go into labor. They go into labor in the community, and they arrive at the hospital. We know that once labor has ensued, there's a pretty good transfer of blood between mom and baby through the placenta and the uterus. And the genital tract. And there is no evidence that running her to the operating room to do a cesarean section provides any benefit. So we would treat her as if she was a high-risk woman in labor, which I'll describe in a moment. I mentioned this just to watch out for all those toxicities I spoke about that can occur with a number of these medications that are specific to pregnancy. A lot of the liver toxicities, for example, that seen with nevirapine, is really specific to pregnancy. And as we start to use newer drugs and we don't have a lot of experience, we feel it's really important to keep a close eye on these women and do blood work every month, looking at their liver function, their kidney function, at their blood levels, to make sure that they're safe. I mentioned here mode of delivery. We do our very best to kind of keep a hands-off approach. Hopefully these women will go into spontaneous labor. And of course, if their viral load is less than 1,000, we support that completely. We do our very best not to intervene in any way, not to break the water early, not to do any tests on the baby while the baby's still in the uterus during the course of labor that would puncture their skin. We hang IV AZT and administer it intravenously to the mom during labor. At this particular dose, and we keep it running until the mom is delivered, or the baby is delivered. The mom has delivered the baby. If no antenatal therapy, or if the woman's viral load is high, we add in a single dose nevirapine and Comavir as a tail after that, just to assist in sort of quickly trying to hit mom's viral load, but more importantly, preload baby, as kind of pre-exposure prophylaxis, as you were. Infants receive oral AZT in a liquid form for up to 6 weeks. It's important that we monitor these babies closely as well. It's not uncommon to see AZT-associated anemia in these babies that's reversible once you stop the medication. So they come for visits every 2 weeks for the first 6 weeks and get blood work done every 2 weeks as well. And we add in extra antiviral therapy to the baby if the mom, if her viral load was not suppressed, even in the setting of cesarean section. And that is just described there in those doses. I mentioned previously the wonderful support we have living in our country. We have support to provide formula for all HIV-affected women for the first year. And certainly we know this option is not available globally. At the present time, in Africa, for example, it is recommended to exclusively breastfeed in the setting of HIV in pregnancy and delivery. The thought is if you mix formula and breast milk, there may be a little bit of a local inflammation in the gut of babies related to the formula or related to maybe some water they've had to use that's not clean. And it can make their gut a bit leaky and a bit more susceptible to acquiring infection through breast milk. And postpartum care really is much like you would with any other woman having had a baby. However, we do know that they are at increased risk of infections. Postpartum, so infection in their surgical site if they've had a cesarean section or in their uterus. We always recommend that they continue their therapy because that is sort of the state of affairs, as it were, now. And prior to them leaving hospital, we always have a contraception discussion. What are their plans? Women will ovulate by 2 months postpartum. Irish twins exist, and I've seen it many times. So it's really important to make sure you have that discussion. And if the HIV was diagnosed in the setting of pregnancy, we always make sure they're linked with adult care, that they have ongoing monitoring and appropriate treatment. They may switch from their combined antiretroviral therapy they're on for pregnancy to a more convenient option postpartum. Neonatal care, HIV PCR is done on baby at birth, at 2 weeks, at 4 weeks, and 8 weeks. If your concern is quite high, if your first few PCRs are negative, this baby's not infected. And maternal antibody, that's kind of a given, clean the newborn before you take the blood. And then there's always a blood test done at about 12 to 18 months of life to ensure that the baby doesn't have HIV antibodies in their system. It can take up to that time for the baby to clear those from mom. We offer hepatitis B immunizations, obviously, and as mentioned, close follow-up. So as my second last slide, I kind of put this together quickly. This is a document available online, and it is a long document with 33 recommendations, essentially about pregnancy planning for couples affected by HIV. First and foremost, their message is make sure any woman of reproductive age is on a regimen that is safe for use in pregnancy, unless they're on a really good contraceptive. And then these next 3 points refer to sort of our recommendations as to how seroconcordant or serodiscordant couples can look into conceiving, and what are their options and what's the safest route. For serodiscordant couples, where the woman is positive and her partner is negative, a home self-insemination is recommended. And this can be done with, quite literally, a turkey baster. This can be done with a syringe that we provide at the clinic. Many couples will use non-spermicide coated condoms and then turn it inside out afterwards. It's very successful. There's been a number of pregnancies at our clinic by this method. And we recommend too that if you haven't conceived by 6 months, come back and see us, because there may be an issue that we can investigate and assist with things. By 6 months, about 85% of couples should have conceived. And because we worry about the potential for any risk of transmission, we would rather investigate sooner rather than let them try for years on end. For serodiscordant couples where the gentleman is positive, we recommend he be on antiretroviral therapy. We know that with a suppressed viral load, the likelihood of transmission with a single act of unprotected intercourse is extremely low. And we have certainly counseled our couples that that is an option, knowing that there is a very small risk. We have also referred couples for a procedure called sperm washing, where through a fertility clinic, and there is one in town that offers this, they will take the sperm sample, wash it, the idea being that any virion that may be present in the semen will be washed away, and intrauterine insemination is carried out in the clinic. Chances, however, that if a gentleman is already on antiretroviral therapy, if his viral load is suppressed, we're not sure that sperm washing adds any additional protection. It might. There are no studies to show that it does, but theoretically it might. Lastly, in terms of, one thing I wanted to mention too about these two issues of serodiscordance. Some of you may be aware of this concept of PrEP, or pre-exposure prophylaxis. So in the setting of a serodiscordant couple, where first and foremost we encourage the infected partner to be on therapy and have an undetectable viral load before trial of conception. If the partner's viral load is not suppressed, we're not going to suggest that you have unprotected intercourse. And in terms of PrEP, the studies that have shown that PrEP is advantageous is not done in populations where their viral load is already suppressed. So our thinking is we don't have data to say that adding PrEP to this situation where one partner's viral load is already suppressed adds any further benefit. We also know PrEP costs about $700 a month. And the average person can't afford that, and at the present time it's not covered. So counseling these women that your risk may go from 1 in 10,000 per sex act to 1 in 10,100 per sex act by taking PrEP, we can't say that. So depending on their level of comfort, and depending on their pocketbook, it really sort of dictates whether or not they use PrEP. For couples that are seroconcordant, so both infected, we also suggest that they are both on therapy because that's what you should do for longevity. There is this notion of superinfection as well, so ensuring that your viral load is suppressed will minimize this possibility. And if not actively trying to conceive, the law would dictate that ongoing use of condoms, certainly in a situation where you have not disclosed, is recommended at all times. Crazy. So in summary then, always assume the possibility of pregnancy in any woman of reproductive age, and for those who are thinking of going on therapy or switching therapy, or for any of those who prescribe therapy, always thinking about reproductive health and what their plans are is important in terms of choosing the safest option. Always offer adequate contraceptive choices. HIV-infected women are candidates for all forms of contraception. We do know that certain formulations of birth control pills or hormonal contraceptives, for example, need to be at a higher level in women on antiretroviral therapy, certain types, just because of an interaction between the drugs. So there are options available, it just has to be at a certain dosage. And if anyone is considering pregnancy and they are HIV positive, come and talk to your care provider, get the information, figure out what it's all about. I'm always astounded how particularly lay people have no knowledge that HIV can actually, transmission can be prevented in the setting of pregnancy. It's just not known. It's remarkable. And it's remarkable what we've been able to achieve. For those who are do not know their status prior to pregnancy, certainly if their test comes back positive in the setting of pregnancy, referring early is the best course, so that they have an opportunity to sort of appreciate the situation, understand what's required of them in an effort to get on medication and reduce their viral load and have a safe delivery. And for a number of our patients as well, one of the biggest challenges, and in fact we're finding this more and more now, in our some of our patients at the O3 clinic, HIV is the least of their problems. That is the least of their problems. They have either other obstetrical issues that put them at high risk, or their lifestyle is so scattered and they're so entrenched in illicit drug use that that's the focus of the care of their pregnancy. So we try very hard to address all of those issues for these women and provide them with as much support as possible to get them through and be adherent and have safe delivery. And I'm happy to answer any questions.
Now, this whole thing is new to me, very informative. But I have a question about certain, how do I rephrase this? Give me a second. In my experience, in my work experience, since the 80s, I've worked with many Aboriginal people through the ministry and through the court in British Columbia. And one of the things that the ministry at that time, the Ministry for Children and Families, was to sort of stand beside the mother who would have a child and be ready to take that child because of certain social issues that the mother or the family have been going through. Things have changed in many ways. That is, the child could probably go to extended family, that kind of thing. But the question that I have today is that how up to date is the Ministry for Children and Families and Social Development, whatever it's called now, in terms of recognizing that many, I'm not saying all, but many of Aboriginal women who are affected with HIV and the possibility of their baby contracting the disease itself. What would the ministry do in terms of confidentiality that the Oak Tree Clinic or any clinic has at that point? Like if I was to work with the Ministry for Children and Families, am I going to stand beside the mother who's going through these social difficulties and is about to have a baby with HIV? How does that whole thing work? Is the confidentiality strictly between Oak Tree and the mother?
Yeah,
or
so,
is the ministry involved?
Certainly the ministry is not always involved, and what's very frustrating for us as care providers is we very rarely know when a ministry flag has been sort of set on a particular case, and they don't get involved until delivery occurs. So we are unable really to even try and engage discussions with the ministry about what their thoughts are, where they're getting their information from, what kind of case or what kind of situation are they building, what are the expectations that this mother needs to do to show that she is a capable and responsible person to care for this child. It's a real puzzle. In terms of confidentiality, I believe that there is no discussion. I mean, the problem is if the ministry contacts Oak Tree Clinic, they know the patient is a patient of Oak Tree Clinic, and that's kind of a giveaway. I do not believe the HIV part of any of this comes into play in terms of ministry deciding whether or not a mother is fit. It has nothing to do with the HIV, even if her HIV is poorly managed. The truth of the matter is, I think if her HIV is poorly managed, it's because of other issues that are probably more paramount in terms of that woman's ability to parent.
Okay, great. Thank you.
I hope I answered that.
Given the higher occurrence of issues of depression in HIV-positive individuals, is postpartum depression given higher consideration for women who give birth?
That's a very good question. So in terms of what percentage of our women would have depression, I would probably estimate that about 10 to 20% of our women are clinically depressed or being treated for clinical depression. We see these women at 2 weeks, 4 weeks, and 6 weeks postpartum. And if we're concerned about their mental health, we have already engaged them with our clinic psychiatrist in their pregnancy. That being said, women can have mild or no depression in the setting of pregnancy, and it can certainly be unmasked postpartum. We know that that's a big time. So anyone that we would worry about, we do our very best to connect them right away. But in terms of no case comes to mind where I think we missed it. But that being said, postpartum depression can happen up to 6 months after delivery, where we're not involved in their care anymore. So that's when it would be important for us to engage their adult care providers. A good question, thank you.
And in an unrelated topic, sperm washing has historically been cost prohibitive for a lot of people. Has that changed?
I don't think so. There's only one clinic in town that's offering it. Sperm washing, I actually looked on the Grace Fertility website the other day because I thought someone might ask me that. I think it's about $100 to $150 per wash. which would be per cycle, meaning sample, spin it, or wash it, spin it down, and then inseminate. The washing itself is probably $100, and the insemination itself is probably $150. You add in some blood tests and ultrasound to figure out if it's the right time of the month for the female, and you're probably looking at about $500 per cycle. It is cost prohibitive. It's cost prohibitive to everybody.
It used to be much more cost prohibitive when Calgary, I think, was the only,
Yes.
when the closest clinic where people had to travel.
Yes.
So it has come down from my perspective. Thank you.
You're welcome. And keep in mind that is only per cycle. And for every cycle tried, there is, and depending on the woman's age, for a very fertile 25-year-old, for every cycle you try to conceive, only 20% actually conceive. Yeah, so it's amazing how many people get pregnant out there.
Okay, thank you for an excellent talk, first of all. My question concerning the use of AZT, I understand why now ethic board will recommend something else because that's the first thing we use and it's effective in some ways. But, and of course, you know, can't use the efficacy of adult response to infant. But isn't there like a way to, because we know the toxicity or like the long-term effect is not that ideal, and we do have other classes of medication that are much safer. I understand why you won't use integrase inhibitor, I understand the reason for that, but wouldn't it be like other, NRTI or something that could be tried? Like, I know the ethics behind it, but it just seemed to me we're like using propeller where we have a jet engine for some reason, because historically we have used it, it works, let's keep using it.
Well, and you know, you're absolutely right. There are much better medications out there. I think what the problem is doing the study on newborn infants, it's going to be a hard one to do. But your point is very well made. We also know, I mean, in the era of ART, combined ART, in the US, they actually don't even do IV AZT to moms anymore if their viral load is suppressed. So we still do it in Canada, and the reason we do it is because we have local information to suggest that even women who are taking all their medications in labor and delivery, their viral load can pop up. So our thought is give the IV AZT to preload baby. We have certainly discontinued oral AZT to the infants when they had a significant anemic response. And depending on the course of the mother's pregnancy and delivery and everything else, we just stopped it. Babies do tolerate the 3-TC and nevirapine if they need to go on that. So change may be afoot, but I haven't seen any research designed for that study to happen yet.
Just one last kind of comment or question. So since 2002, I guess there were no babies born in BC that received care, or the mother received care that were positive, which is great success. Congratulations on that. Are there like, but I do know that there are some people who are. What kind of like long-term effect are you seeing use of ARVs or treatment on infants that are progressing with HIV as an infection?
So very good question. One of the things I wanted to put in the slide that I didn't is that at our clinic, I think we're at 4 or 5 now. We've delivered uninfected babies to perinatally infected women successfully. So there's been a generation of babies born HIV infected who have been managed to the ages of 18 to 22, and now they're having HIV uninfected babies, which is wonderful. Complex because of a variety of reasons, usually drug resistance, but those women who, how many women have we had a year? I wish I had a graph. Probably no more than anywhere from 0 to 2 a year would be infected in BC that we're aware of. A, that would have the testing done, and B, in the setting of pregnancy, and maybe acquired it later on in the pregnancy. So there's actually, in the US anyhow, there's a move on to actually repeat HIV screening in the 3rd trimester, particularly amongst those women who are high risk. I mean, it makes perfect sense. But it's evolving into standard of care south of the border, so that may come here too. But for the most part, those women who, I'm not sure if I'm answering your question right, but there's anywhere from 0 to 2 per year, and it's typically in those women who are either undiagnosed or simply cannot and do not engage in care, and they're simply lost to follow-up. They move to another province, or they come to this province and don't seek care. Yeah, but for the vast majority, those women who you'll meet at the beginning of their pregnancy, and I think there's such a long road for them to stabilize. It is remarkable what they can do, yeah, with the right supports.
Thank you.
Hi, so I have two things to mention. And one, I love the stats, and I'm actually one of the moms from the 509.
Fabulous.
So yeah, my little girl Destiny is 13. So I was actually at the BC Women's Chew, and it was a frightening time. And I had gotten actually clean and sober off the downtown east side in February 2nd. Found out I was pregnant on the 18th of February, and I gave birth to her, natural birth to at BC Women's. And to answer the gentleman's question in regards to Ministry of Child and Family, because I had 6 other children before that, and they were in foster care for about 2-3 years. And when I went into the clinic, and it was from my background with substance misuse, where I was put into a certain unit at BC Women's, like the fur unit and stuff like that, because I was considered high risk maybe for using again, and I didn't use for my pregnancy. And but there's always social workers there in that unit, so they were just always coming in to check on you regardless. If you're in one of those certain units, it means you have some kind of a past with ministry already, and I had a long past with them. And but they were there to support me in good ways. So I stayed in sobriety, and they were there to help me in other ways with homemakers and stuff at home and stuff. My daughter, though, and I was kind of touching on the last person's question there, is I started the AZT, I guess, in my 3rd trimester. I remember not having any meds until I was about 6 months, and then I continued giving it to her until she was 6 weeks after. And then she had to go through the ugly blood work for 18 months, right? But she, gratefully that she's doing well. She does have some learning disabilities today. I don't know, like dyslexia, she doesn't really retain information as well, but she's still very bright and stuff. Mm-hmm. So I don't know if there's been any side effects in regards to the medication that she was put on even after I gave birth to her.
Right. That is still being investigated. I'm sorry I didn't address that aspect of your question. We know that there are, for example, any of the drugs that might have an impact on the mitochondria. There are a number of studies ongoing following babies who are exposed in utero. It's a study called the KARMA study, which I'm not sure if anyone's familiar with. Essentially, it's a multidisciplinary group. It's from across Canada. We're following as many HIV medication exposed but uninfected infants in a longitudinal fashion, looking at their growth, their neurocognitive status, their health, sort of a number of predictors of health over the course of their lifetime. And so far we're finding that things are okay. We do know, as we learn about some of these newer drugs, that, for example, tenofovir used in pregnancy may have an impact on baby's bone development and kidney function. So there are a number of studies following tenofovir exposed babies. One study found that they were a centimeter shorter and their heads were a centimeter smaller at 1 year of life compared to those unexposed to tenofovir. So we're learning. We don't know whether or not that's sort of a long-term effect.
I guess because I have a joint custody with ministry and my daughter.
Yeah.
So I have her on weekends and stuff. And since she's been mostly in the care, I guess she's seen a physician for Ministry of Child and Family who have her on, this is how she's said it to me about 3 years ago when she was about 10. Oh, Mom, they have me on pills for my attitude. Right? They have me on a pill to make sure I go to sleep when I should. Right? And a pill to take when I go to school so I'll pay attention. And of course, that just drew a whole lot of red flags for me, right?
Sure.
They gave ministry a call, and they called me into her office. They said, so Flo, did you drink and drunk with her? Right? And I said, no, I didn't. I knew I didn't, right? And they didn't really believe that. It was kind of like, just gave me that look in the dog, right? So to me, I think ministry, maybe they have Dr. Death, or, no, I don't want to say that, that's really judgmental. You know, whoever their GP or physician is that's dealing with the kids, and I know it's one main person and stuff, and I spoke with the foster mom, right? So it's unfortunate my little girl has to take all these meds. And I had her for her first 6 years, and she was totally fine without meds. She didn't need anything, so,
Yeah.
you know, but anyhow, that's why I was asking about that, and if there are, it's glad to know there's some studies, and I'll
There
look into it.
absolutely are, absolutely
Yeah.
are, through Overtree Clinic, and I mean, I'm actually surprised your daughter hasn't been contacted to
Yeah.
participate. But it's active, and there are many different facets of health and outcomes that are being studied, right down to the telomere lengths of your DNA.
Awesome.
They're being looked at.
Thanks.